So for part 2 of our lecture on medications for mental disorders, we're going to start by talking about antipsychotics, or drugs that treat that category of mental disorders called psychoses. So the first group of drugs, the first ones, beg your pardon, wrong slide. Okay, here we are, antipsychotics, phenothiazines. So this was an early group of drugs that was used to treat psychosis. And they were the first group that really reduced the symptoms of the condition, the symptoms of psychoses, without sedation, like narcosis therapy that we talked about in our previous lecture. Initially, they were called tranquilizers or neuroleptics. So if you've heard those phrases used before, those terms used before, it's a group that's now called antipsychotics. So this actually, we have some long-term concerns about the use of these drugs, but in general, when we started using drug therapy for victims of schizophrenia, for patients with schizophrenia, we saw a really dramatic decrease in the use of inhumane approaches like restraints and convulsive therapies for patients in psychiatric hospitals. So they weren't perfect drugs, but they definitely led to a dramatic improvement in treatment and quality of life for people suffering from these conditions. So now we consider those typical antipsychotics, and then new sets of drugs, or atypical antipsychotics, use a different mechanism of action than this earlier class of phenothiazines. All right, now we're ready for this one. How antipsychotics actually work. So we have our two groups, typical and atypical antipsychotics. So in general, typical antipsychotics, these work because they are dopamine antagonists. They block receptors for dopamine. And of course, one of the long-term concerns that we have here is this condition called pseudoparkinsonism. So basically, through long-term use of the drug, we see symptoms very similar to the condition of Parkinson's disease. It's not a simple mechanism, and there's things that we still don't understand about it. Mostly, there's a long delay in from when the drug is first consumed to when it starts to affect the condition, and it means that it's probably a more complex mechanism of action than the straightforward blockage of dopamine receptors. So our second category, atypical antipsychotics, these are still antagonists, but these are serotonin and dopamine antagonists. They block multiple sets of receptors, and we see lower rates of pseudoparkinsonism among people who use these over a long period of time. In general, antipsychotics tend to be relatively safe drugs. One thing that we really worry about drugs that are administered to this population is that they're difficult to use to commit suicide. It may not be something that we can be concerned about in a more stable population, but we are using this drug for a population that is mentally ill. And they also tend not to create drug dependence, so they're relatively safe from that perspective. They do, however, have some serious side effects, including allergic reactions, sensitivity to light, changes in blood chemistry, pseudoparkinsonism that we talked about, so symptoms similar to Parkinson's disease, tremors, shuffling walk, difficulty with facial expressions, and then the most serious complication of long-term antipsychotics treatment, tardive dyskinesia. So some real serious concerns about using these drugs over the long term, but of course the condition that they're treating is also extremely serious. When we start to talk about the effectiveness of antipsychotics, we do find relatively high rates of effectiveness over short-term use. Unfortunately, by the time we get to about 18 months out, we find that 3/4 of patients discontinue use. Could be related to the long list of unpleasant side effects that we just discussed. It could also be that people just feel better and they no longer feel like they need to take the medication because they feel like they're no longer suffering from the illness. In terms of the typical versus the atypical antipsychotics, there's no clear evidence that they work differently, although we do see lower rates of side effects with that newer atypical group. In terms of use of children and the elderly, in children, we see a particularly high risk for weight gain and associated risk for diabetes and cardiovascular problems. And then in the elderly, we actually see a significant increase in all-cause mortality, specifically related to cardiovascular disease. So some definite concerns, although it's important to keep in mind that the condition that's being treated is one that is also extremely serious. Okay, so moving on to a category of drugs that we may be more familiar with. Next, we're going to be discussing antidepressants. These will be a couple of different categories. We'll talk about MAOIs, or monoamine oxidase inhibitors, tricyclics, and then selective reuptake inhibitors. And we're going to start with the MAOIs. If you've heard that phrase before, we hear it sometimes in drug advertising, not to be taken with MAOIs. That's what that stands for. So the mechanism of action here is that MAOI inhibitors increase the availability of serotonin, norepinephrine, and dopamine. We're back to that same set of neurotransmitters that we talked about with our stimulants as well. But the mechanism here is that instead of blocking the receptors, it's going to inhibit the breakdown of these neurotransmitters. So we're still increasing the availability of the neurotransmitter in the synapse, but we're doing it through a different method. So these are still in limited use, or they're now in limited use, because of side effects and toxicity related to taking these drugs. If you've ever heard about not being able to use MAOI with aged cheeses, so certain dietary restrictions for people who are taking these drugs, it's because fermented foods like aged cheese and sauerkraut contain an enzyme called tyramine that actually blocks the effect of the MAOI. So some unusual characteristics of these drugs. I don't really have any brand names to refer you to. These were more popular in the 1950s, and we don't see as much use in the current era. Okay, so tricyclic antidepressants. These were actually discovered by accident by researchers who were looking for an antipsychotic drug. And what they ended up with was a drug that was not effective against psychosis, but it did elevate mood. So the mechanism of action here is that they work by increasing, again, serotonin, norepinephrine, and dopamine, this time by interfering with the uptake. So the MAOIs interfered with the enzymatic breakdown. Tricyclic antidepressants interfere with the reuptake. We find that they're not effective in all patients, but if they do work, then they reduce the severity and duration of depressive episodes, so some good results. Now, ones that you may be more familiar with, the drugs that we tend to hear more about here in the 21st century, Zoloft, Prozac, Paxil, Celexa, Lexapro. These are all selective reuptake inhibitors. So the drugs that we're most familiar with tend to fall into this category. We have got two types. We've got SSRIs and SSNRIs. So the S is for selective, and then the SSRI, serotonin reuptake inhibitors, and then for the SSNRIs, we add norepinephrine to that list. So same neurotransmitters, same group, and they increase the availability again of the neurotransmitter by interfering with the reuptake. We find that they're safer than the tricyclic antidepressants, and they're less likely to lead to overdose deaths. We have gotten some new warnings, though, recently about increased risk of suicidal ideation and suicidal tendency in children and adolescents. Clearly an important concern when we're talking about antidepressants. Another category of treatment for mental disorders is electroconvulsive therapy, or ECT. We talked about this a little bit when we talked about earlier methods of treatment, and this is one that we have held on to in limited circumstances. For people with severely debilitating depression, this can be their most effective treatment. And for cases with risk of suicide, this can be the best treatment choice. It is also often used in conjunction with drugs. And when we compare it to the effect of pharmacotherapy, or using drugs to treat the same problem, we find that ECT actually relieves symptoms faster, and it may be more effective than drug-based approaches to treating depression. It's still not in wide use, and it does face some stigma based on its history of of less humane uses in cases of mental illness. Just another quick category of drugs that we'll talk about is mood stabilizers. The most common of these is lithium. So lithium is actually a mineral, and it's used to treat mania and bipolar disorder. And it actually treats those conditions quite well, but it really has not been widely used in the United States. There's a couple of different reasons why. Partially it's related to the chance of lithium poisoning. It is toxic at high doses. And there's also a perception that the conditions that it treats are not serious disorders, but mostly it's financial. Because it is a basic chemical element, it can't be patented. No one can own the rights to this, and there's really no financial incentive for any particular company to promote its use and its distribution throughout the United States. So without that financial incentive, we don't see it being promoted along with other kinds of drugs, and really no incentive for any company to take up that role. Now, it definitely can be toxic. Those poisonings were definitely due to lithium dose, so blood levels must be monitored if someone is on lithium. And then we also have a problem here with a high rate of non-compliance. Patients who experience mania and then go on lithium tend to talk about feeling dull or having their senses, feeling like their senses are dead, that they just don't have that burst of energy or maybe creative influences they talk about when they're in the middle of a manic episode. So they tend to be very unhappy with the consequences of using that particular substance. So it does work. It can help prevent not just mania but also depression, and we don't really know why. It doesn't seem to work on people who are just suffering depression. It really seems to be in people who have that bipolar, the swings between depression and mania. And we do have a couple of other mood stabilizers available. Those are actually anticonvulsant drugs that have a list of serious side effects. So not a lot of good options available for people who are experiencing these symptoms. So when we look at the role of medications for mental disorders, the pharmacotherapeutic approach to treating mental illness, we did see a really dramatic decline in the number of patients who were confined to psychiatric hospitals as those drugs became more common. So you've got the average daily census, or the number of residents in psychiatric institutions in the United States by year, and we see that really steep drop through the 70s, 80s, and 90s as patients were placed on these drug regimens. And we also saw some pretty dramatic changes for the role of the psychiatrist. So typically before this time, a person going to see a psychiatrist would expect to spend long periods of time in treatment, lots of Freudian-type talk therapy. And we saw a change in the role of the psychiatrist where they weren't doing so much of that. And their priority was really on finding the appropriate drug regimen, getting the person stabilized on their medication, and then sending them back on their way. So a real decline in the use of that talk therapy. And it really did address some important civil rights issues as well. It was relatively easy to be committed to a psychiatric institution in that middle part of the 20th century, and people could be committed for indefinite periods of time for reasons that they were maybe difficult to deal with. We saw it among young women who were exhibiting sexual behaviors that were unpopular in their communities or their families. They'd be committed to psychiatric institutions, and they may never be released. It could be committed for lots of different reasons, and it became an important civil rights issue. In 1975, it was deemed unconstitutional to have a person indefinitely committed. So we see this additional of a periodic review of the patient's status to see if they're continuing to present a danger to themselves or to others. If there's no danger established, then the patient is released. And of course, there's some very serious concerns with this as well. So the patient may very well have their symptoms very well controlled while they're in the hospital on a well-controlled regimen, well-controlled schedule for administering those drugs. But once they're released into their on their own, they may stop taking that medication, especially if there are side effects that they don't enjoy. And even though once they go off that medication, they may be dangerous to themselves, they may be dangerous to others, and even if they're not specifically dangerous, they may be too ill to take care of themselves. So what we end up with is the issue of imprisonment and homelessness. More mentally ill people are admitted to jail every year here in the United States than are admitted to state mental hospitals. So we see this high rate of mental illness among the prison population because we really don't have any other facilities in place to care for them here in the United States. And we also see a very high rate of mental illness among the homeless population. About a third of all homeless people have some form of serious mental illness. So while we've recovered from the excesses of involuntary indefinite commitment, we don't really seem to have found the right balance yet in terms of caring for people's long-term mental health needs. So we've ended up with just one lecture here today on medications for mental illnesses, and we discussed the medical model of mental disorders, some people who have challenges with that and why that might be, and some common groups of disorders. We talked about early treatments, the history of treatments for mental illnesses, including things like malaria therapy. And then we talked about some current pharmacotherapeutic options for the treatment of mental illnesses, and then the changes that came about as a result of those. Thank you, and I will see you for our next lecture.